Hi to everyone. It's really a pleasure to be here. I am Rimini Margherita from Milan, from the San Raffaele Hospital. In this presentation, I will talk about our work on the different genomic landscape between IDH1 mutated and IDH1 wild-type cholangiocarcinoma patients. IDH1 mutated cholangiocarcinoma constitute a group of neoplasia of particular interest in the biliary tract oncology due to a particular behavior and therapeutic implications. IDH genes encode for 3 different IDH enzymes, which are known to play an important role in the cell metabolism. The gain of function mutations of these genes lead to DNA and histone hypermethylation, to genetic instability, hypoxia gene signature activation, oxidative stress, and affectation of mTOR C pathway and the mitochondrial electron transport. The discovery of mutation in IDH genes has revolutionized the therapeutic approaches and opened a new research way investigating target therapies capable of inhibiting the aberrant activity of the mutated enzymatic isoform. To date, a number of IDH1 inhibitors under investigation, and imatinib received the FDA approval in advance and the metastatic cholangiocarcinoma patient with IDH1 mutation due to the promising result from the randomized phase 3 trial Clarity. Recently, high-throughput genomic sequencing technique permitted to highlight the heterogeneous genomic scenario of cholangiocarcinoma harboring IDH1 mutations, but no conclusive data are already available. The aim of the present work was to deepen the molecular landscape which underlie IDH1 mutated and wild-type cholangiocarcinomas. Moreover, we investigated the prognostic role of the most relevant genomic alteration by performing a survival analysis for PFS and OS in both IDH1 mutated and wild-type patients. For this study, we retrospectively selected the 247 consecutive patients with cholangiocarcinoma treated for resectable, for locally advanced or metastatic disease in 6 Italian institutions and 1 Spanish institute from January 2013 to March 2021. This sample included patients diagnosed at the local stage who received radical surgery, patients who relapsed after surgery, and the patient diagnosed at the locally advanced or metastatic stages who were judged no candidate to surgical treatment, thus exclusively received systemic treatment. Molecular and genomic analysis were performed through the Foundation 1 assay. As reported in the first table, in our sample, 125 patients were IDH1 mutated and 122 wild type. No significant differences were found in terms of clinical pathological characteristics, except for the gender in the 2 groups of patients. Interestingly, in the whole cohort, we identified 22 frequently mutated genes, of which 15 were highlighted to be actionable according to the database by the Broad Institute. A comparative analysis of the IDH1 mutated group and wild-type group of patients highlighted differences in terms of mutation distribution and molecular landscape. Overall, IDH1 mutated cholangiocarcinoma show a lower incidence of mutations compared to the wild type. If we focus on a concrete gene alteration, IDH1 mutated patients show higher mutation rates compared to wild type in CDKN2B, and lower mutation rates in several genes, including TP53, FGFR2, BRCA2, ATM, and MAP3K1. In the survival analysis, we considered the cohort of rejected patients and those of patients receiving first-line treatment, thus highlighting the differences in terms of prognostic mutation in IDH1 mutated and wild-type patients, as we can observe in this table. At the univariate analysis for a disease-free survival from surgery conducive for the most commonly altered genes in our sample, in the IDH1 mutated group, the presence of CDKN2A, CDKB mutations were likely to have a C-negative prognostic impact, whereas no one gene showed to impact on prognosis in terms of disease-free survival from surgery in the IDH1 wild-type group. At the univariate analysis for overall survival from surgery in the IDH1 mutated group of patients, the presence of a CDKN2A, CDKN2B, and PBM1 mutations were likely to have a C-negative prognostic impact, whereas no one gene showed to impact on the prognosis in terms of overall survival from surgery in the IDH1 wild-type group of patients. At the univariate study for the PFS from the first line conducive for the most commonly C-altered genes in the IDH1 mutated group of patients, the presence of KRAS and RAS and TP53 mutations were likely to impact on prognosis, whereas only the presence of MTAP mutation was likely to have a prognostic impact on PFS from the first line treatment. At the univariate analysis for OS from the first line treatment conducive for the most commonly altered genes in our sample, IDH1 mutated and wild-type patients show a different behavior too. In particular, in the IDH1 mutated group of patients, the presence of a TP53 and PIK3CA mutations were likely to impact the prognosis, whereas only the presence of TP53 mutation was likely to have an impact on prognosis in terms of OS from the first line. In conclusion, despite the limit due the retrospective nature, we perform a comparative genomic study on a large sample of cholangiocarcinoma patients, thus highlighting molecular differences between mutated and wild-type patients, and interestingly highlights on the prognostic role of genomic alteration were done. Once validated, our results could add new pieces to the puzzle of the heterogeneous scenarios of cholangiocarcinoma, with the ultimate goal of opening the way to further researches on new therapeutic strategies depending on the genomic signatures.